All right, let's go ahead and get started. So I want to welcome you all to our final didactic lecture of the year. And before I hand it off to Dr. Hassan to deliver his presentation on VTE, I want to just briefly introduce him. Dr. Ali Hassan is an internist and associate medical director at Three Crosses Regional Hospital in Las Cruces, New Mexico. And in addition to his work at Three Crosses, he also serves as teaching faculty at Burrell College of Osteopathic Medicine and as a teaching physician at Memorial Medical Center's Family Medicine Residency Program. Dr. Hassan completed his MD at American University of Antigua and served his internal medicine residency at Las Palmas del Sol Hospital in El Paso, Texas. Now, before I hand it off to Dr. Hassan, if you have any questions during the lecture, we ask that you place them in the chat and he will get to them at the end. Dr. Hassan, the floor is yours.
Perfect. Thank you so much. Hello, everyone. Thank you for the introduction. Can you guys hear me clearly?
Yes.
Okay, I'll take as a yes. So quick learning objectives. So basically, we'll go with the definition of venous thromboembolism, which also known as a DVT, upper extremity deep vein thrombosis, lower extremity deep vein thrombosis. We will review the etiology, causes, risk factor, comorbidities, basically common presentation, and then we'll discuss the diagnostic modalities, and then the indication and contraindication for the treatment during inpatient as well as outpatient, then some complications of treatment, and then some practice questions. So disclosure none. So we'll start with the practice questions. If you guys want to answer, not quite sure, they can type in the chat now the answer. I'll give you 1 minute.
Yeah, they can type in the chat, or we have a few people here. So I mean, if they want to turn on their microphones and
yeah,
answer,
that's fine too.
Yeah.
Actually, I like that idea. Somebody, any volunteers? Or should I start picking on people? I know some of you. I'll give them a minute to read and then. All right, I'll read. 73-year-old male is admitted to the hospital with pneumonia. He has stage 3 colon adenocarcinoma. He went about 2 months ago, colon resection. He has begun his chemotherapy already. All right, go ahead, whoever.
I think it's enoxaparin.
Okay, you want to read the question? So basically, what they are asking, right? Of course, you know the answer already. So what's the diagnosis, or what the question is asking?
I think they're asking for DVT prophylaxis.
Okay, and enoxaparin, good. So do you see any abnormal or anything wrong with the enoxaparin other than the spelling? So the spelling are misspelled. All right. So basically, you are right. The answer is DVT prophylaxis. So I'll Ronnie, you want to read the answer as well?
Sure. The patient after the cancer itself. So hospitalized patients with cancer have an even greater thrombotic risk. But the prophylaxis in medical patients with enoxaparin trial enrolled 1,102 medically ill patients who were randomly assigned to receive one of the 3 subcutaneous regimens: enoxaparin sodium 20 milligrams per day, enoxaparin sodium 40 milligrams per day, or the placebo. The frequency of VTE was reduced in a statistically significant manner in patients receiving enoxaparin sodium 40 milligrams per day. For hospitalized patients with cancer and acute illness, pharmacological prophylaxis should be used unless a clear contraindication exists.
Yes, perfect. So basically, this question is asking, everyone should be, they did a study, and of course, they enroll different people. Who whoever comes to the hospital admitted, it's observation patient or it's an inpatient, everyone should be started on DVT prophylaxis. Mainly the most common we use, because it's very easy to use, is enoxaparin is like standard dose 40 milligram daily sub-Q, or let's say if they have acute kidney injury or renal failure, so then you can use heparin 5000 TID, unless if they have a clear contraindication. So we'll go over the contraindication. Some people actually they don't want, right, sub-Q injection. So just be mindful, make sure you write down, or the nurse will call you, hey doctor, this patient does not want injection. You can tell the nurse, I'm not going to discontinue, just let the patient document every time we offered, because there was a one case involved, just to prevent litigation. So patient refused first day DVT prophylaxis, second day, and third day he did not. So the nurse, without, I'm not sure if they informed the physician or not, she just discontinued, even though we were documenting. And the doctor assumed that the nurse already documented, but third day she did not offer, fourth day did not offer. Eventually he got DVT. So the lawyer, or the judge was like, did you offer every single day, since you are getting, at the end of the day, you are getting paid every day, so you have to offer your services every day. So the main point is you have to offer them DVT prophylaxis unless there's a specific contraindication. If there's a contraindication, always document. Why? Because documentation will prevent you, even though you assume, you will verbally tell the patient. If you don't document, it means it did not happen. So make sure you do. There's young people, like for example, they come for acute pancreatitis. Hey doctor, I don't want it. Okay, sure. So you're like, patient refused, but recommended to walk 4 times with a nurse or by himself, as well as putting SCD, sequential compression devices. So make sure you document. All right. So basically, DVT is a very basic definition. Is a blood clot that forms in the deep veins of the body, upper extremity, lower extremity, in the brain. So most often occurs in the deep vein of the leg, either above the knee or below the knee or upper extremity, or in the sinus venous thrombosis, which is kind of DVT as well. So basically what happened, then DVT can thromboembolism. So thrombus is basically clot, embolism when it starts traveling. So then a thromboembolism can cause multiple complications, such as pulmonary embolism, like a embolism to the brain. So what is it's a basic pathophysiology. You guys remember something called Virchow triad. It's I think in medical school, probably you heard that. So basically what happens is either there are different 3 main reasons why it happens. Damage to the endothelial lining of the wall, then hypercoagulable state, it becomes hypercoagulable state, and then venous stasis, and then eventually DVT can form. So some mortality and morbidity. I got these numbers from CDC website yesterday, so probably pretty updated. So in US, there's an estimate that about 60 to 100,000 people, Americans, die because of DVT, PE, directly or indirectly, or basically complications such as PE or such as embolism to the brain. 10 to 30% of them died within the 1 month of diagnosis. So of those, studies show that sudden death is one of the symptoms. Actually, before even were diagnosed, they die, and then the sudden death is one of the complication of it. And in about 25%, we can see those people will have a PE or DVT, but mainly PE. Also, a study showed that about 33%, if they had once, they will more likely going to have another DVT. It's a leading, actually, it's one of the leading cause of preventable hospital death in the States. It's the VT is the 5th most frequent reason for unplanned hospital readmission after surgery, and the 3rd most among patients, mainly people who go after hip or joint replacement. So where I work now at Three Crosses and of course Memorial, at Three Crosses we do a lot of hip and joint replacement. So inpatient for internal medicine or family medicine, we're supposed to put them on whenever your hemostasis achieved. For example, after 4 hours is the mainly, there's no contraindication after, let's say if they have a hip replacement or a knee replacement, when the hemostasis is achieved within 4 hours, you can start a prophylaxis DVT, Lovenox or heparin. But in orthopedic world, there's a one article that shows that 81 aspirin milligrams PO 2 times a day also prevent DVT. So if it's an orthopedic surgeon, he will usually start that for DVT prophylaxis. Why? Because it's very easy. And I did read that article myself. I should have included it. And it did show actually they compare heparin or Lovenox and aspirin, and aspirin did a pretty good job. So that's why the surgeon orthopedic will usually put 81 milligram PO/BID or 325 milligrams PO/BID. So mainly I seen 81, but at Memorial I seen a few orthopedic surgeon will put 325 milligram PO/BID. So for the hip and the knee, usually is 24 to 28 days of DVT prophylaxis. Going that, recent study of US hospitalization found that hospitalized adult with certain pre-existing health condition, for example, AIDS, cancer, arthritis, congestive heart failure. Cancer is one big that I did not add it over there. They are more likely to be diagnosed VTE than hospitalized. So then patients who don't have these comorbidities. So basically, don't forget your DVT prophylaxis. Several studies, including last year million women study. There was a study that was done. It's also very important. Surgery for abdominal or pelvic cancer, they face a higher burden of getting DVT within 1 month. In another trial, Roster's trial, 40% of those surgical cancer patients, 40% VTE occurred after discharge. And then, of course, they had either a late onset DVT or a early onset DVT. So basically, it is saying that patient who have, let's say, any abdominal surgery and the patient is elderly and history of either had a history of previous DVT or a history of cancer. So they have any abdominal surgery because they are less likely to move. And I've seen a lot in real world that they do develop DVT. So what we do is usually, for this case, the surgeon, OB-GYN or general surgeon, they will recommend Lovenox 40 sub-Q for 7 days or 10 days. But again, only on those patients who are high risk, given previous history of DVT or ongoing cancer. So cancer increases your risk a lot. So what are the few risk factors that can increase DVT, risk of a DVT? So there are two risk factors. One is acquired. Acquired means you get it, like, for example, and then the inherited, you inherit, for example, those from affiliates. So older age, after 40, by default, you have more risk of DVT comparing to 20-year-old. Obesity, BMI more than 30 is linked. Recent surgery or injury within 3 months, surgery mainly intra-abdominal or orthopedic. So basically, any surgery, if that is going to hinder your mobility. If you have, let's say, a hand surgery, very unlikely. Use of estrogen-containing contraceptives like birth controls, pills, patches, hormone replacement therapy. Remember this question in family medicine board, actually this question came. So they always give 42-year-old female, she's, or let's say 36-year-old female, she's a smoker and she want to be in hormonal replacement therapy. I think we don't put them or tell them to quit smoking because they have a very high risk of DVT. Pregnancy and postpartum period up to 3 months after childbirth, or even prepartum, there's a high risk of DVT. A previous history of DVT or a family history of blood clots. Active ongoing cancer treatment or recent cancer treatment. So these are the few medications that may increase tamoxifen and then lenalidomide, all of those. Immobility is another one. For example, if some young dude had a fracture and then there's a hard leg cast, he's not moving much, so there's a more risk. Another one is catheter placed in enlargement. For example, if we put IVC catheter or any central line in a bigger vein, like femoral catheter, there's a more risk of DVT. History of varicose vein. So I've seen that in varicose vein, usually you might have a DVT, but very small one. And of course, our classic long distance traveling when we don't move, and then there's a more risk of DVT. Inherit venous thromboembolism causes are factor V Leiden is one of the most common prothrombin genetic mutation, protein C and S, antithrombin, dysfibrinogenemia. So these are your inherit. So probably I should have an added over here. Once someone get diagnosed up to age of 40 of like spontaneous or unprovoked DVT, then of course we always try to investigate and get all that thrombophilia workup. Either we do ourselves or send to the hematologist. So this chart basically go over in certain patients or in certain area of the hospital that, or mainly in a certain diagnosis, increased risk of DVT. In, for example, medical patient, they are more likely to get 10 to 26% of DVT than normal, like not admitted patients. Gyne, urology, general surgery, they are more likely to get 15 to 40%. Neurosurgery, stroke, hip surgery, spinal cord injuries are one of the most common. So let's see if you have a general surgeon on case as always. Of course, we have to listen to them. Then if usually they're pretty good about putting a DVT prophylaxis, but sometimes they leave the drain. So drain is not basically an absolute contraindication unless if it's draining a lot. So you can friendly ask them or remind them, hey doctor, is it okay if I put prophylaxis DVT, or you want just SCDs? Make sure, of course, they have to have SCDs and encourage them to ambulate. So how does the DVT present? Classic symptoms of DVT include swelling of that local area, pain, discoloration in the involved extremity. Mainly, you guys probably seen more DVT in lower extremity, but we'll talk, it does exist in upper extremity as well. So there's no like absolute necessity or a correlation between the location of symptom and the site of thrombosis. So basically, if you might have a pain in the calf and you might DVT is in femoral because the pain is somewhere else and the symptoms are somewhere else because of the backflow or blockage of the blood. Symptoms are in the calf alone. Calf is one of the most common manifestation of proximal vein involvement, while some patients, they might have a whole leg pain, and mainly the pain is worsened when you walk or put pressure. In addition, a complete thrombosis history include, so basically you can ask history or try to figure out the location of thrombosis, get their family history, ask them if they ever had a history of family history or first relative degree history of DVT, and if they are having any, like if they're on chemotherapy or any vascular collagen vascular disorder. So how do we diagnose, physical exam for DVT? Of course, we look at mainly vascular system, extremities. We look for sign for superficial or deep vein thrombosis. You'll feel like a palpable cord, like very unlikely, but you might feel it. Probably you guys know hormone sign. Usually it's not very specific. And examine their heart and lung. Look if they are physically like tachycardic. It's mean they might have PE already, or look for abdominal organs. If you can look for any enlarged liver, you know how they have a blood clot in the superior venous thrombosis, those ones. In skin, you can look at skin necrosis, levator reticularis. There might be some pain and tenderness to that local region area. You might have some pain in the, like for example, calf muscle, but it's not a diagnostic. It's one of the, it helps you basically to one of the differential diagnoses. It helps you to narrow it down. Many patients are asymptomatic, so sometimes and sometimes they do have symptom edema, mainly on one side is also one of the most specific symptom, actually edema. Next is if probably I've seen only one case of phlegmisma sorella dolens is very hard to pronounce, but Dr. Reimer he knows how to pronounce. So this is this is a special, when you have a DVT and then there's a lot of package of the blood, and it's very painful. So let me show you on next slide. This is basically a picture. See, the blood clot is the blood return is totally knocked out, and now you have massive swelling causing compartment pressure, causing a lot of pain. So just treat this. If you've seen patient in ER and you see the dark red, painful, it's very painful, like upper or lower extremity, you have to call the interventional radiologist or a vascular surgeon right away. So this is basically a disease, very uncommon. You'll see it's a life-threatening. It's a complication of DVT, marked swelling of the extremity with pain, cyanosis. It may cause it because of the swelling so much. It might also cause arterial ischemia. It can cause gangrene, and within eventually it can lead to amputation, and mortality rate is pretty high. So treat as a emergency. What are the few treatments? Basically, timely restoration of the venous circulation is important to save the limb. You can do once you call IR, just make sure you start heparin, of course, and do keep in mind, like if there's no contraindication. Let's say, God forbid, if the patient had a hemorrhagic stroke 5 days ago, then you have to be very mindful when to start, what not to start. So so you can start a heparin drip, and then call interventional person, so they can do pharmacological thrombosis, where they put a catheter and put a TPA or a ateleptase, those kind, and then surgically do the embolectomy, suck that clot out by the catheter. One of the study done by Ventham on different 28 patients with acute DVT revealed that phlegma had a clot removal rate of 80% compared with 26% in thrombectomy alone. All right, so much enough. And this is another picture of DVT, basically, not DVT. Oops. Reticularis. All right. What are the few differential diagnoses for the DVT or VTE? So basically, a muscle strain can cause pain, a tear or injury, 40%. So basically, other differential diagnoses, of course, you do keep in mind. Sometimes patient is bedbound, and if we don't move over extremities, their limb might get swollen, so paralyzed limbs. Lymphangitis or lymph obstruction, venous insufficiency. Sometimes there's a rupture for Baker cyst, which can also mimic DVT, cellulitis, any abnormality, and then there are unknown causes, some other causes that are not DVT and not listed over here. Now we'll quickly go over upper extremity deep vein thrombosis. So upper extremity account for about 5 to 10% of all cases DVT. And now the cases are actually increasing because we put so many central lines and so many lines in big like subclavian or intrajugular catheters. Most common site of upper extremity involve the axillary and subclavian veins in your right here. And then, however, the more distal branches can also or may be involved. Primary upper extremity DVT is less common than secondary one, and most secondary causes are effort-induced. We'll go over something disease called Paget-Schroeder syndrome. it's basically a Paget Shorter syndrome is a venous form of thoracic. It's relevant to thoracic outlet syndrome. It occurs in young athletic people who basically are baseball, for example, a baseball player who repetitively throw pitch, and cause irritation or injury to the vein, and then thrombosis can happen. Secondary causes like that we also induce are due to intervalling devices such as central venous catheter, pacemaker, defibrillator leads, tunnel catheter for hemodialysis. Uh, there was one study that they did. It compared. It showed that 93% of all upper extremity in one. It was a retrospective study that showed that central venous catheter is one of the main culprit, and it does increase risk by 14 folds. So basically, removing unnecessary lines, like if we don't need, just try to remove it. Um, so one of the complication of upper extremity DVT is it can of course cause pulmonary embolism, as lower extremity also can cause that. So there's about 5 to 8% of risk in patient with upper extremity that can cause PE, and the mortality risk is 0.7%. How do we manage? So basically it depends on the etiology. For example, if there's a catheter and remove that catheter, and we just treat as a regular with heparin or Novex or Dovex, just like lower extremity. So let's quickly go back on that Paget Shorter disease. I had a patient in the other hospital. He moved from California and recently joined NMSU baseball team. So within within 6 days, he came to the hospital with like crying, cursing, pain 10 out of 10, and in his he was righty, so in his right hand, right upper extremity. We thought it might be a rupture. It might be basically arterial rupture, or of course DVT, or some other, maybe he was malingering. So we did ultrasound, and ultrasound was negative because ultrasound is less sensitive. And then I called intravascular surgeon, and he was very concerned. He repeated ultrasound maybe in 2 hours himself, and then of course it was positive. And then if the ultrasound is not, if you still have a high suspicion and it's less, since it's less sensitive, then you can get CTA or MR venography, which is more sensitive. And do make sure you write when you order something. Do make sure, always do that. Like, what are you looking for when you order some test? So so the radiologist know what to look for. And of course, in this our patient, what we did was our vascular surgeon, Dr. Latif, he took him to the OR. We started immediately heparin drip. He took him to the OR. He put catheter, and he put some ateleptase, TPA, and also mechanically, he did actually both mechanically suck that clot out and brought him to the ICU. But he's within like 4 hours, what happened was his pain again was back to the level 10 out of 10. We did ultrasound, and guess what? There was another clot. So he took him back to the OR, and then he constantly for next like 4 hours or 6 hours, he was getting more and more and more clots. So even though he was on heparin drip, and then I had to call the oncologist, and she was okay. We can do a dual anticoagulation. So we did a heparin and therapeutic enoxaparin as well. We admitted him in ICU as expected. As I said, he did develop thrombosis. He had minimal reperfusion symptoms, and his neurovascular was basically intact. This is a picture. You can see all that blue. These are the DVT upper extremity. So deep vein thrombosis. You treat them as a lower extremity thrombosis, as a lower extremity DVT. But sometimes you can have very minimal. You know how the nurses put IV line, and sometimes the small clot can happen in the IV line. That one in superficial veins, we really don't need to treat with anticoagulation. Basically hot and cold massage, and your body should be able to take care of it. Let's move to the lower extremity deep vein. So these are the few, as you guys know, the anatomy of the lower extremity. You can go over yourself, but femoral vein is one of the most common vein that DVT occurs. So how do we diagnose? Of course, everyone we can, for risk stratification, the most common criteria used is Wells criteria. So basically, Wells criteria is paralysis or recent orthopedic casting of lower extremity. You get 1 point. Recent bedridden for more than 3 days. More than 3 days, or major surgery in past 4 weeks. 1 point. Localized tenderness in the vein system. Swelling of entire leg. Active cancer. Other diagnosis, alternative diagnosis more likely than DVT, then you minus actually 2 points. So then according to the probability, if it's 3, it's very likely get ultrasound. If it's moderate, still I'll get ultrasound. If it's very low probability, then look for other causes. That's your Well criteria. On the other hand, if you have a high suspicious or you have a gut feeling, it's okay to get ultrasound. So, and let's say if a patient comes in, if you have a low suspicious application of the clinical development. So if you have a low suspicious, just a basic ultrasound, very cheap, they can do in the ER, they can do anywhere. You don't have to move the patient. The tech will come to perform the ultrasound. It's negative, good. If the compression abnormal or inconclusive, then we can do venography, MR venography, or just venography. Abnormal DVT present, it can rule in or rule out. If you have a moderate suspicious, again, if it's abnormal, which means DVT is present. On the other hand, if we have a moderate suspicious, repeat ultras, you need to repeat. The first one is normal, but then you can repeat another again in a week or so if the patient continues to complain. On the other hand, if there's a high risk or high suspicious, then same thing with the sometime we do skip ultrasound, but again I will prefer to do ultrasound. It's very affordable and very easy to get one. On the other hand, D-dimer, we can also use D-dimer. Basically, D-dimer is excellent to rule out DVT. So different labs have a different cutoff and different, it has varying sensitivity and specificity. So you use per your lab guidance. If it's negative, it's mean DVT is ruled out. But on the other hand, DVT, elevated D-dimer, there are so many other causes. For example, if the patient has a trauma, so thrombosis can happen. A recent surgery, of course, it's a mechanism of forming a clot. So that's why by default, your D-dimer will be high. D-dimer on average remains about 7 days. It remains elevated about 7 days. In few causes, for example, MI, of course, thromboembolism. These are the other few causes that you might have elevated D-dimer. DIC, severe liver disease. Your liver is not able to clear the fibrinogen or the bioproducts. Nephrotic syndrome, for example, renal vein thrombosis. Your D-dimer can be elevated. It's very useful, basically, D-dimer, very useful tool. So if you think a patient might have a DVT and you have a low suspicion, just get D-dimer, very cheap. If it rules out good, if it's elevated, then of course ultrasound. All right, so ultrasound findings are basically what in the report, what will you read, or what the radiologist will read, is abnormal compression of the vein. You can have abnormal Doppler color flow, presence of echogenic band, and I don't know if my mouse will work, but at the blue color indicates the venous flow is good, and the red one indicates there's a good blood flow in the arterial part. But those small white specules, they can basically indicate they are non-compressible and may it can suggest DVT. Let's say if your tech is out or your ultrasound machine is broken, then CTA or MRI is also, we can use MRI as well to diagnose the DVT. In pregnancy, I believe I don't practice that much OB-GYN, so MRI in the second and third trimester pregnancy, MRI is more accurate than ultrasound. So we can use MRI to diagnose any DVT in, but again, it's very expensive. We can also use venography vein. Basically, it's a dye where we inject in the veins to look for any blockage. And if patient, let's say if you're looking for pulmonary embolism and we cannot do CTA, then we can use VQ scan as well. All right. Any volunteers to read this question? So a 25-year-old brought to the ED because of shortness of breath, right side chest pain for 2 days. Look at that, 2 days. She has no orthopnea, lower extremity edema. Medical history is unremarkable other than anxiety related to meeting her demands on new job. She takes no medication. She's in no apparent distress. Vitals are normal. Oxygen is normal. Lungs are clear. No peripheral edema. Her Wells criteria for PE is 0. Normal labs. What you want to do next? So in this case, everything is pretty okay, and look like she might having a panic attack with some shortness of breath. So unlikely she will have a PE. So you basically reassurance. There's no further test. So this patient requires no further testing for pulmonary embolism. Many patients, they come to the ED because of breath or chest pain. If we start using too much inappropriate use of D-dimer and CT angio, lead to the development of new American College of Physicians guideline regarding the evaluation of patient with possible pulmonary embolism. So these guidelines use clinical decisions or PERC score to risk clarify for your PE. I know we are mainly covering DVT, but I thought it might get too boring if we continue on same topic. All right. So once you diagnose, so you can either diagnose the DVT inpatient or outpatient in the clinic. So how to initiate, or where do you initiate your treatment? So these are very relative contraindication for starting someone on treatment. We'll talk about treatment very soon. So sometime if you diagnose, let's say as an outpatient, if you think patient has a high risk of bleeding, or if there's some active bleeding going on, you basically don't start anticoagulation, send them to the hospital. We'll monitor them for a day, start anticoagulation. On the other hand, if it's a recent surgery, mainly a surgery that is relevant to like vascular surgery or mainly vascular surgery, or if you think there'll be high risk of bleed, then you don't start DVT outside. But if they have recent surgery, let's say cataract surgery or breast biopsy, you can start as outpatient. On the other hand, if you diagnose DVT or pulmonary embolism, if they have serious venous obstruction symptoms, for example, if your pain is like whenever the patient walk, hey doc, I cannot put pressure on my leg, then you send them to the ER, and then we can admit the patient, and then start heparin drip and see if the patient needs a mechanical thrombomylectomy or need a catheter guided atelectasis to break that clot. If the patient is high risk of PE, if there's ongoing, you think there's a PE, for example, shortness of breath, needs oxygen, chest pain, then we can start anticoagulation to admit to the hospital, start anticoagulation. Platelets, thrombocyte, if there's thrombocytopenic platelet less than 50,000, we can bring them in and see if they have any ongoing bleeding, or if they are high risk of bleeding, then we won't. But if they are not high risk of bleeding, then we can start and monitor for 24 hours, 48 hours. And if the platelet is stable, then we can send them out. Any other causes, if they need to be admitted to the hospital, then of course we can admit and then treat both the other cause and the DVT. If you think the patient is non-compliance or patient is very poorly educated, so sometimes we admit them and then like try to teach their family or try to explain them to the patient. Sometimes if the patient don't know how to inject himself, so bring to the hospital, the nurse will teach him. Next one is poor hepatic function. Since this is the first time ever you are starting the anticoagulation, so it's iffy. If you, so it's a good idea to bring to the hospital, admit for 1 day, and start them on treatment. If they have a new onset or rising serum creatinine or acute kidney injury, of course, you know how you have to, for example, let's say heparin, or if it's a Lovenox, you have to really adjust, so we can bring them to the hospital and treat their AKI and DVT. So some relative absolute contraindication in our before starting treatment, for example, active hemorrhage. If you can see if there's a hemorrhagic stroke or active hemorrhage, any going like GI bleeding or upper GI, lower GI active bleeding, or basically any active bleeding you see. So it's kind of absolute contraindication. Then of course you give the option, you explain the risk, the benefit, the alternative, then your suggestion, and usually the patient will agree that don't start. Severe trauma to the head or spinal cord with hemorrhage in the last 4 weeks. I had a patient, so he had a head trauma and there was suspected hemorrhage at the hospital, newly diagnosed DVT. We basically repeated the CT scan and saw there was no progression of the bleed. We started him, kept him 1-2 days, and he's repeated. Not he had no clinical symptoms, so I did not really repeat the CT scan. I sent him out and told to follow with the PCP. Some relative contraindications are intracranial hemorrhage within past 2 years, past 1 year, craniotomy if they have for some reason within 2 weeks, and again you do assess the risk and benefit. Intraocular surgery, GI bleed, thrombocytopenia less than 50,000, or PTT more than 18 seconds. If they have end-stage liver disease, it's a relative. So basically you compare risk and benefit and discuss with the patient. Hypertensive crisis, just try to bring their blood pressure down and then start them. And then postpartum bleeding concerns. There are some causes in, for example, heparin-induced thrombocytopenia. Then of course you start treating them, but we'll go over with different medication than heparin. Inpatient, again, if you suspected or proven DVT and PE, you start, if they are for some reason they are already inpatient, you can start them right away. If they have symptoms of cardiovascular or pulmonary, we'll skip this. So basically, these are the one of few of the causes where you recommend them again to admit them in inpatient and start the anticoagulation and monitor. So always DVT, always ask, is it provoked DVT or unprovoked? Because of the treatment duration, and if it's provoked, then you know already that. So then let's say if patient had a hip surgery 2 weeks ago, comes to the clinic and newly diagnosed DVT, then you know the provoked was basically a hip surgery. So you start for 3 to 6 months, and then you just reevaluate the patient. If it's unprovoked, and then if it's unprovoked, young, less than 40, or unprovoked, usually less than 60, then you can you have to figure out the cause of it. You can order hypercoagulable workup before starting the treatment, and then you can start the treatment. Sometimes we do inpatient, sometimes if we already started the anticoagulation, then it makes no sense to start the hypercoagulable workup inpatient. Then you can follow up, complete the course for 3 to 6 months with hematologist, then stop your anticoagulation for 2 weeks, and then get the work, and then if needed, we can put them back. Right now, because of the convenience, we start patient mainly on the NOAC or DOACs. They're preferred because of convenience, and we don't have to monitor in labs, and they're little low risk of bleeding compared to warfarin. On the other hand, if there's no other option, for example, if patient failed NOACs or patient cannot afford, then warfarin is our also treatment. This is a quick chart. Basically, it will we can quickly go over it will basically tell how to diagnose and when to start, or how to start. So how do you select one? So first you determine the phase, initial phase. How do you start the treatment? So you start determine which phase they are in. Initial phase, first few days, then primary, first 3 to 6 months, and then secondary phase is beyond 3 to 6 months. So you have different options. Some of them you can start in first phase, initial phase. For example, Pixaban, it because first phases mean they'll start working right away. Like you don't need a therapeutic INR. So initial Pixaban you can start, and you can continue. Dabigatran, we really don't use that, so we cannot start in first phase. So we'll go to the next slide. Again, basically this slide is telling, I just put some studies. They did different kind of trials comparing Xarelto with vitamin K antagonists such as like warfarin. So Xarelto rivaroxaban was not inferior to vitamin K dependent as warfarin. Apixaban is, there was also a trial which did not show if it was non-inferior to Lovenox or vitamin K agonist. Prodexa, dabigatran also, it was non-inferior. All right. Question. So this is a 45-year-old man is evaluated in the hospital for worsening pain and swelling of lower extremity. We started suddenly about 12 hours ago. Physical exam, his pulse rate is 112. Other signs are normal. He has erythema, marked edema of the entire leg. So he has a significant, basically, burden of the clot, and he's very symptomatic. The foot appears cyanotic with decreased sensation. He has absent arterial pulses. So it's mean there's a significant amount of clot burden that is already impending or impairing the arterial blood flow. There's a delayed capillary refill. Otherwise, physical exam is normal. And then you did ultrasound, and then ultrasound showed significant extensive iliofemoral DVT. What you want to do next? So in this case, because he has a significant amount of burden of the clot, so basically we need to call interventional radiologist or vascular surgeon, where they can inject direct tissue plasma and plasminogen activator, and they also can do mechanical thromboembolectomy to remove that burden of the clot. Otherwise, you know how we start heparin. Heparin basically prevents the propagation and further development of clot, so heparin won't help. So thrombophlebitic therapy with ateleptase is the most appropriate management in this patient because his symptoms and signs are so extensive. He has a lot of edema. It's already compromising arterial blood flow and causing acute ischemic injury. He is very, very high risk of amputation of the leg and more risk of death. Results of a systemic review of thrombolytic study showed greater improvement in venous patency, increased complete clot lysis, and reduced post-thrombotic syndromes compared with the anticoagulation therapy alone. And these are the reasons why we did not study the direct. For example, argabatrin is a direct thrombin inhibitor. They are reserved for, we don't start them, they are reserved for heparin-induced thrombocytopenia. Unfractioned heparin potentiate the natural anticoagulant activity of antithrombin 3 and act as a non-specific, it's a non-specific anticoagulant. And IVC filter is one of the last resort where there's a contraindication. For example, patient is having GI bleed, or for some reason we cannot put them on anticoagulation. Also, let's say if we start, so usually we do not administer low intensity warfarin regimen, so basically our INR is supposed to be between 2 to 3 whenever we started someone on DVT treatment with the warfarin. So we just cannot, how your liver synthesize the warfarin, so we cannot do we cannot lower the dose. So whatever the standard dose, each patient has different. Some require 2 milligrams daily, some require 5 milligrams. So we can go up and down, but depending on the each patient. So after treatment, we can follow up, we can assess the patient either on annually basis after we completed the treatment, or if the patient is already is going through the treatment, we can reassess in 3 months to make sure the patient is taking it and it's adequate and is not getting any symptoms from it. Or if there's a new like contraindication or any new contraindication, then sometime we might have to take them off. Quick slide. Let's say if we started some follow-up patient on NOACs, we usually check their function and blood flow at 1 month and then every 6 months. So switching from vitamin K like warfarin, if the to NOACs, if their INR is less than 2, we can start same day of let's say Eliquis or whatever new drug you want to start. In between 2 to 2.5, you wait for 1 day and repeat INR, and if it's below than 2, then you can start. If it's more than 2.5, then sometime we can calculate the half-life. If someone is already on anticoagulation and then develop another recurrence of venous thromboembolism, so then of course we ask them verify the compliance. Sometime we reassess their concomitant medication. You know how CYP 450, those enzymes, they can increase or decrease the therapeutic or the dose of the anticoagulation, like warfarin. Make sure if they are always in normal therapeutic INR. So on the other hand, now the trend is becoming actually more if the patient can afford and have easy access to NOAC, try to switch to a NOAC. Overdosing with active bleeding, we manage per depending on the complication. If we need to reverse it, for example, vitamin K, we give them vitamin K and fresh frozen plasma if someone is on warfarin and has having acute uncontrollable bleed. And then these new drugs I did not cover much, but most of them has a antidote for them. One more question. A 59-year-old man is validated in the hospital for swelling of his left leg. He was admitted 5 days ago. 5 days ago with DVT and bilateral permeabilism. We studied low molecular heparin on day 1. His medical history is he has CHF. He was hospitalized 1 month ago for pulmonary edema. Medications are lisinopril, furosemide, metoprolol. Physical exam. Temperature is 100.6, blood pressure is normal, pulse 104, respiration rate 24, oxygen 91%. Both right and left legs are swollen to mid-thigh. Lab shows hemoglobin of 12.8, WBC leukocyte count of 11,200, platelet of 78,000. At admission, his platelet was 168. Ultrasound discloses a new left vein thrombosis. So, did you notice anything in the labs? If you look over here, his platelet basically dropped from 168 to 78,000. So somewhat near 50%. So and now also, even though he's on heparin, but he developed a new clot. Of course, you have to treat that clot. and he's not actively bleeding, so there's no contraindication to start anew. What would you do in this case? So basically, of course, he's developing heparin-induced thrombocytopenia. So you will discontinue the heparin and any heparin molecular product. So discontinue low molecular weight heparin and start basically argatroban, which is a direct thrombin inhibitor. It works different mechanism of action than the low molecular weight heparin, and it is therapeutic right away. And choice B is wrong, because if you're discontinuing one product, one form of heparin, then you won't start the next one because he's having heparin-induced thrombocytopenia. Insert an IVC filter. Now this is the least useful option, or this is one of the last resort. And overlap low molecular, you won't continue because you'll further become thrombocytopenic, and your heparin-induced thrombocytopenia will worsen. So in this case, the most appropriate is to discontinue heparin and initiate argatroban. This patient has a hit since he was in the hospital 1 month ago for chronic renal failure, and most likely he probably received subcutaneous heparin for the DVT prophylaxis. So he had exposure. So what would you do is to calculate your 4Ts. So high risk scores are associated with the high 4Ts. So next page it will show you what are the 4Ts. High probability scores are associated with 50% decrease in platelet count, onset between 5 days and 10 days of heparin exposure, new thrombosis, and there's no other cause of thrombocytopenia. So in this case, his platelets drop more than 50% from admission. He already has a new clot because the heparin is not working, and there's no other cause of explaining thrombocytopenia. So probably he has a hit. Hit can be a life-threatening condition if we don't treat appropriately, and it's very time sensitive. So in this case, heparin should be discontinued, and then you have to put him on alternative therapy. Immediate effective anticoagulants, the one that don't need like a INR check, or sorry, a therapeutic INR. So basically, argatroban is the best option. It's a direct thrombin inhibitor. It will work right away. How do you diagnose HIT? So this slide will cover a little bit, and next slide as well. There's a strong positive immunoassay for HIT, which will confirm the diagnosis. The risk of thrombosis. So even though if this guy is a HIT, so there's a high risk of again developing rethrombosis after resolution of thrombocytopenia. So we can begin therapy with warfarin in few days when the platelets become normal, and we can continue 3 to 6 months because he's a high risk of developing another thrombosis or clot. So if the hit is suspected, we calculate their 4T scores. If low, then unlikely, find another reason. If it's intermediate or more than 4, right away we discontinue heparin, start non-heparin product or anticoagulation. You get immunoassays negative, it rules out. But if it's positive, you continue to avoid heparin probably for lifelong, then obtain functional immunoassays. So there are 4Ts are, you basically calculate, just give me 1 second, let me put the slide down. So you give points to, you calculate the point. For example, 2 points is platelet more than 50% fall, 2 points clear onset between 5 to 10 days, or platelet fall less than 1 day because he had exposure within past 30 days. There's a new thrombosis, or basically, so each will give you a 4 point, and there's no other cause. So he's very, very high risk. So you calculate the points, and then depending on the scoring, 2, 4, 6, then it will basically it will do the risk stratification to see if patient has a heparin-induced thrombocytopenia or not. All right. So there was a study done back after 2010, I think 2012, 14 or 16. So it was it enrolled a different population, and basically it was patients who were diagnosed with atrial fibrillation and was started on apixaban, rivaroxaban, and that we get. And so there was a risk, as well as people who are using systemic fluconazole. So basically, there was a 5.1% increase risk of bleeding on patient who are taking Eliquis daily, along with the fluconazole. But on the other hand, there was they found no increased risk of bleeding following exposure to topical azole. So basically, PO fluconazole did not really mention if it was like, it did not mention for how the dosage of fluconazole. I did not happen to see that, or the duration. So it could be just maybe for longer course of period, or it did not really specify if they were using basically like a one dose of fluconazole for Candida UTI. But Eliquis did increase risk of Pixaban, so keep that in mind as well. So this is a resource over there. Also, this. So I believe this is the last slide, but also what would I recommend is, or what we do is, if someone is on long-term anticoagulation, for example, Novax mainly, or warfarin, for if they get admitted to the hospital for some reason, and you believe he's a high risk of getting like any procedure, that patient, or any surgery. So what I do is stop the NOAC, because half-life usually it's 48 hours should be enough, unless if they are going for major vascular surgery, then usually the surgeon will say 3 days, 3 to 5 days. So what I do is I will stop the Eliquis PO, or a Pixaban, or Rivaroxaban, or warfarin. Warfarin not that much, unless I have a high suspicious or high patient is likely to get any surgery. So that the second, third day, if the patient needed any elective procedure or surgery, so that day will be he will be cleared for surgery and low risk of bleeding. Meanwhile, you can bridge with the Lovenox. All right, that was last slide, and a few resources. You can see I got a lot of stuff from UpToDate, Medscape, Mixup 18, and then some resources or references were already embedded in the PowerPoint. If you have any questions, you can text or you can email me on this email. Please feel free. I'm available anytime. Thank you.
All right, Dr. Hassan, thank you very much for joining us today.
No worries. Thank you.